Have you ever wondered what it would be like to practice dentistry in another country? Maybe just for the sake of interest, or perhaps because you're considering a sea change. And this podcast series is for you. Listen in while we ask key clinicians from our main dental protection jurisdictions about their practice experience and ponder the unique challenges and opportunities experienced by dental practitioners in their part of the world. Hello, my name's Dr. Annalene Weston, dental legal consultant with Dental Protection based in the Brisbane office in Australia. And welcome to What's It Like to Practice as a Dentist in South Africa. And today I am absolutely thrilled to be joined by Dr. Ridhwaan Haffajee. Hi, Ridhwaan, how are you?
Hi, Annalene. I'm well, thanks. It's great to be here.
Excellent.
Thanks for having me.
So thrilled that you are. I'm just going to start off by reading your bio for some colleagues who may not have met you before, so just bear with me. So Ridhwaan is a Cape Town-based specialist prosthodontist with a strong focus on implant dentistry, restorative rehabilitation and clinical education. He completed his specialist training at the University of the Western Cape and is a fellow of the International Team for Implantology. Ridhwaan lectures locally and internationally, works with leading implant and dental companies, and has presented at global congresses across Europe, Asia, and South America. Beyond clinical work, he's deeply invested in mentorship, teaching, and helping clinicians navigate both the technical and human sides of dentistry. Would you be a demonstrator or a lecturer at the hospital?
I would be a clinical mentor, a little bit both. Let's call it clinical
Uh-huh.
mentor.
Well, a little bird told me that you're their favorite. So it's nice to know you've got one. So thanks, Ridwan. Like I said, so Cape Town, South Africa, beautiful city.
Love it.
Um, can you just start off, please, by telling us a little bit about your background and why you chose dentistry over something else?
It's a tough one because it's not. I wish I could say there was some amazing story behind it. I'm from Durban originally, so I've always lived on the coast. Brisbane is similar to Durban, similar demographic, type of weather. It's very much like Durban. And I grew up there, very middle class family. We are fourth generation Indians, so I think Indians came to SA probably 170 years ago.
Gosh, okay.
And I think culturally, education is one of the most deep-rooted philosophies of our culture. It's one of those things that you always laugh and joke about as a kid, thinking that you got to be the doctor, accountant, lawyer, and a dentist if you didn't get into medical school. And the honest truth is, why did I do dentistry? I don't know. It was one of those moments in grade 11, sitting around having breakfast with my parents. I remember that morning saying, I want to be a dentist. And I think if I did not get into anything, if I didn't get into dentistry, I probably would be quite unhappy because I don't have that deep, exciting moment of why I did it, but it happened and I'm extremely grateful for it. I think looking back now, one of the reasons also was that a profession that gave us almost a guaranteed income. So we didn't have the opportunity of studying something that was, I may get into this sector or may get into that sector, whereas you knew doctor, pharmacist, accountant, you're going to start working and you're going to have a job. So I guess there was elements to it, but from an actual dental perspective, I think it brought in technical elements that I enjoy. As a boy, we like playing with building blocks and we like breaking and making things. And then from the healthcare perspective, you get to work with patients and change people's lives. So I think you bring those two elements together and dentistry falls slap bang in the middle of that.
No, I agree. It's really fulfilling if you, it's like they say, don't they? It's that dentist, artist, engineer. It's that you're all
There
those
we
things.
go.
And it's funny, I know we've talked about this before, but my dad's from Durban and he was really adamant when I was growing up that whatever job I had to be able to be financially independent and I could never, ever, ever rely on anyone, never rely on a man, never rely on anyone, be really financially independent. And it was really strong messaging that I was given as a child. And I think it's, look, it's helpful messaging, but it's also partly what led to me going into dental practice, as you're saying, having that guarantee of a job and a job where you can help people. It's very powerful. I think we're very lucky. I think we're very lucky. So we mentioned you do some uni work. What's your current practice makeup then? Because I know you're a specialist and I know because we've talked about your clinic, but just go through for me. What's your makeup? What does a Ridwan's week look like, I guess, or month?
So Private practice is in essence a multi-specialist practice. So in-house, we have myself as a prosthodontist, we have two periodontists, we have two oral hygienists, a general dentist, and we have a consultant endodontic practitioner that comes around. In South Africa, we don't have something called an endodontist. Largely, you get an individual who's done his diploma, master's, and then closes off his clinical work to endodontics only. So it's a very touchy term. So we don't have, so prosthodontics encompasses implantology, the non-surgical part of it, as well as endodontics. So my week is working within this multi-specialist practice, and I would spend classically 1.5 to 2 days a week at the university, either working with undergraduate or postgraduate students, depending on the day or the clinic and the space that I'm in at that time. I think to touch on the multi-specialist, that was a very intentional decision that myself and Fahim, who was my periodontist, the practice that we decided we wanted to work in that space. I think it's important in two ways, or multiple ways, and we're probably going to unpack it a bit more. But clinically, it really brings value to patient care when you're working in a space that's collaborative. You're no longer working from an egocentric perspective. You're working where you have to work as a team. And you're also being accountable to someone beyond just your own conscience, which is important in dentistry. Um, and then from the other aspect, just psychologically, it's great to go to work and say, "Hi, good morning, how's it?" Rather than just having the receptionist, your assistant, and perhaps your admin lady. I love the fact that we work. It's almost an extension of being at university again, where you've got colleagues walking down the corridors. Yeah,
That's great. We do talk a lot, as you know, about the isolating nature of dental practice or how isolating it can be. And it's wonderful on the one hand to be able to be your own boss and structure your practice the way that you want and only do things that you want to do. But when you do exist in that vacuum, it can become a little bit of an echo chamber. So that you're quite correct, having colleagues, not just from that mental and emotional well-being perspective, but having them just to bounce ideas off. And we can't always be all things for all patients, right? We wish we
yeah,
could be,
100%.
but we
But
can't
it's
be,
not
and
always
even
there.
as a specialist. So I'm super curious. You've mentioned the university. I have very little understanding about, um, I know that you have a huge number of applicants for dental school. You have 4 dental schools in South Africa. Is that correct? Or is
Correct.
that,
Yes, yeah. Yes, that's
and
correct.
about 50 candidates in each one, I think?
Yes and no. So we have
Okay.
University of Western Cape, which is in Cape Town. We've got the University of Witwatersrand, which is in Gauteng, Johannesburg. There's University of Pretoria, that's also in Gauteng, and what we call the old Medunsa, or it's known as SMU. That's in also Gauteng. So it's 4 dental schools. The 3 latter ones would accept between 35 and 55 dental students. UC will have a number of closer to 90 to 100.
Gosh, okay. Much bigger
So he
school.
started much bigger. So he's apparently it's the largest on the continent. Uh,
Oh, wow.
hasn't been validated recently, but I remember when I was a dental student, it was the largest.
That's what you were told, yeah.
And the reason why it is like that is originally there was the University of the Western Cape and there was the University of Stellenbosch.
Yeah.
I think it was in 2002 that they had a merger between the two faculties. And I think from then the numbers, at that time it was about 30 per class. Now they just merged it and kept the numbers closer to 90. There is something in KZN, University of KwaZulu-Natal, where they offer dental therapy, uh, but not dentistry.
Okay, so
But
there's a separate
that's a
therapy school. Okay,
there's a
that's
separate therapist.
interesting. That's interesting. I didn't realize that. And how long's the degree?
That's a 3-year degree. It's a 3-year degree. Doesn't have community service or internship. We have community service, sorry, after dental school.
This was where I was going to go. Yeah. So dentistry is not 3 years. How many years is that?
5.
5. And then you guys all do a compulsory community year, don't you?
Community, yes, correct. Yeah.
Yeah. Okay.
And the therapist would have 3 years, and I think they would do a 1 year in service at a dental practice where they work under a dentist.
Okay.
Yeah.
Interesting. Now, the
Um,
community practice, can you tell us a little bit about that? Would that be okay? Because you must have done that,
yeah,
and
yeah.
then I presume you went and then did your specialty afterwards, or did you do some time in general
Yes.
practice and then do your specialty, if you see what I mean?
Yeah, good point. So community service is mandatory for all South African practicing graduates. Um, Look, there's clinics within the city itself, so you could be doing your community service in Cape Town, living at home with mom and dad and traveling 10 kilometers to the local clinic. But those posts are very few. For myself personally, I knew that I was I was unmarried, had no kids, I had no property, so I was going to get community service in the truest form that you'd go out into rural areas. And so I made my pick and I found the most beautiful part of KwaZulu-Natal, near St. Lucia, just up north coast past Richards Bay. And there was a military base out there, and I chose to do my community service here out there. There are financial incentives of working out in the rural area or in deep rural, so it's not entirely just slave labor. You get to really enjoy the year as well. And I chose the military because the military did offer an element of general dentistry. So I could still do cleanings, crowns, dentures, the whole works. Whereas classically doing your community service here in a government institution, you're largely limited to extractions um, for the most part. And you spend a year doing this, and I thoroughly enjoyed it once again because it was the same multi-specialist type of center. There was doctors, dietitians, pharmacists, and you get that spread of engaging with other practitioners within your clinic, which I enjoyed. And I think it was something that I chose specifically that I wanted to have. For those that work in government clinics would largely do extractions. They get to work at 8 in the morning and till 4 p.m. and you're just offering pain and sepsis relief for the most
Yeah.
part.
Yeah. No, I can
Which,
understand that.
yeah, I think it's also based on the approach of the practitioner. You could go out there and think, man, all I'm doing this year is just extracting teeth. It's such a waste of my knowledge. But you can also look at being it's 1 year of your life that you are giving back of value to a community that otherwise doesn't have access to healthcare beyond what you're offering, in a
It's a
dental
service.
space, obviously. And you make the year what you want it to be. There's guys who will go for that year and paycheck to paycheck, ride out the 12 months. But I know of guys who go out there and truly engage with patients, enhance the soft skills of dentistry, feel the humanity of the people that you're working with. Because largely working in South Africa, that demographic happens to be 50% of our population. And we often go into private practice and you live within this bubble of privilege and think that's not representative of what the country or the people of our country are. So I think it's important that we use that year to see and feel what really happens out in the world.
No, it's really powerful. And I
Um,
think I met when I was over last year at your conference, I met some clinicians who'd continued in community, like they'd stayed and that would then been what they'd dedicated their lives to, which I think is wonderful because I think we do lots of amazing things, but relief of pain is actually a very basic way or simple way of really changing someone's life because dental pain sucks.
100%. Yeah, 100%. And I think something that we also should think about, most patients don't like a dental experience
No.
because of childhood trauma. And something that I've seen in my career, and it hasn't been a very long career, but I've seen it already, that you have patients who've been patients of a community clinic at some point, and now through the process of education and career development, now return to a prosthodontist for specialized implant care, but still live with that painful moment of when community dentist carried out an extraction in an insensitive manner. And we got to remember that that patient is a human being who will grow throughout life, and we also have a responsibility of managing that individual in him finding the profession rewarding or somewhat rewarding.
Yeah.
So and I think these are the little nuances that come with community service, and unfortunately, it's only hindsight that gives me that opportunity of seeing it. But I'm hoping that platforms such as these can change that perception of how community service can be approached.
We need to change the narrative. I was reading a really interesting article the other day about how bad we are at actually getting patients properly numb. You know, you're talking about people having those bad experiences and how few people actually have profound anesthesia when we do treat them. It was really no number. It was something like 30%. Because I looked at it, I was like, wow, that's quite frightening when you think about some of the things that we do to people and they don't like it. Well, you can't exactly blame them. So you did this
And
year and then
and we tell them it's pressure, not pain, right?
pressure, right? You're just feeling
Yeah.
pressure. I know. As long as we tell them how they're feeling, I think that's terribly important. Okie dokie. So you did that year, and then did you go back into practice or did you just specialize straight away? I'm curious.
No, so in South Africa, I'm not sure how it is globally, but you have to do minimum of 2 years of general dentistry.
Yep, sure.
Obviously, it is advantageous to do the general dentistry in the field that you're interested in specializing in, but you would classically spend a minimum of 2 years before you get into general dentistry. And in this time is when you would write certain examinations. So in your specialist time, which is 4 years, you would write so-called primary examinations, which is written in the first 12 months of your program. It's basically your anatomy, physiology, pathology, oral biology, and then you write intermediates and finals. So you can, however, write primaries before getting into the registrar time or your residency program. So I wrote it in that time, so just boost your CV a little bit more to make you look like a more appealing or intentional candidate, rather. So in this time, I wrote my primaries and I sat my a diploma at the university. And fortunately, I got in pretty quickly. So I got in within those 2 years. Hindsight, once again, would tell me that I perhaps should have been delayed by another 2 years. I think there is a big element of clinical skills and knowledge and also just gaining life experience. I'm still, but at this time, I'm probably 26, 27 years old. The registrar program can be quite daunting, can be quite grueling. It does require a lot of diligence because for the greater part, it's self-learning. You have senior mentors that are there to manage and guide you. Uh, and you're also now working in the university space. You're dealing with personalities who've been there for 25, 30, 50 years. And managing their history, their background, their perceptions. And as a 26-year-old, 27-year-old, you may not always have the wisdom of understanding the sensitivities that come with this. So perhaps I think if I got in a little bit later, but you tell 27-year-old Ridhwaan, let's wait 2 more years before you get in, and he's not going to like you either. Uh,
He
yeah,
wouldn't have
so
been on board, would he, 27-year-old
he
Ridwan?
wouldn't have
He would
been
have
bored.
very much thought that he was good to go
Yeah,
right now.
there we go. But I think with that being said, you also don't want to delay too long. You don't want to
Mm.
go in deep into your 30s. One, from a clinical perspective, you pick up bad habits, you become set in your routines and your ways. And at the same time, life happens. Most in their 30s are now married with kids and have life commitments. And to go back to uni and specialize does put a big damper on that part of life. And I think sometimes as dentists, we forget that we need to balance both evenly and equally, or we should. Um, so
No,
yeah, I got in at
absolutely.
that time.
Absolutely.
Uh, the difference, I'm not sure how it works globally, but in South Africa, our registrar time is uh, salaried. So we still pay university fees, but we do earn an income in that time. Uh, and it goes back to being our, our universities being state funded or state subsidized rather. So our incomes would rather be by virtue of treating government patients in that time, and that's where our learning does happen.
Yeah. No, that's great. Thank you. So I'm curious then, we've touched on this whole community clinic service aspect. So some countries have something similar where there's like a year that you do. Australia, you're straight out into practice when you graduate. So very different. But the UK, I did something called vocational training. It has a different name now. So it's not something I'm unfamiliar with. So I think that's one distinguishing characteristic for dentistry in South Africa. And also you mentioned about the cohort, about that big gap, I guess, between, you still mentioned the bubble. Can you think of some other distinguishing characteristics which might be quite unique to South Africa compared to, say, me in Australia? It's not a test. I'm just curious.
Yeah, yeah. I think the first thing that comes to mind is income. In your community service year, you earn You earn some good bucks. You're coming from being a broke student, and now you're earning some good money for 12 months. And the year after community service, you're now left to go into the open world. Uh, Very small percentage of practitioners are retained in their positions. So you're now, in essence, unemployed. And where do you find work? So you end up working as associates or locums, as we would call it. And you're earning a commission. No work, no pay, no patients, no pay. I'm not sure how it works out in the UK or in Australia, but financially, this does put a big hit. And working through your community service here and saving and having a bit of a war chest of funds available to keep you through till you now find work that is also income generating and sustainable. Because at the same time, you end up in practices which has another vast demographic. You've got practices that would treat, in private practice, Cape Town, you would treat patients who come in for extractions only, and it would be 200 and an extraction. And if you're earning, I'm not sure how many dollars that would be, less than 20.
So it's 20 bucks, roughly.
20, yeah, $20.
And so
So
about
you're earning
10
20
pounds.
bucks an extraction, 20 bucks an extraction, then you're taking 40% of that. You got to pull a lot of teeth in a day. Um, and that can be challenging finding that practice. And at the same time, higher end practices are going to be reluctant on taking you on because you've got no experience.
Yeah,
I'm not
yeah, for
sure how it
sure.
works out in Australia, whether it's the same dynamic of how that would work
It depends.
on your
Like a
side.
lot of the young ones, when they start, they actually do multiple jobs, 1 or 2 days here and 1 or 2 days there.
Yeah,
And then they will have to build their list in one of those practices. So there are some practices that churn through young clinicians because they're not necessarily fab and wonderful places to work. There are other practices that will take a young associate on, genuinely mentor them, like not just say they're going to mentor them, and actually help that practitioner develop and grow. And interestingly, those associates sometimes never work anywhere else. They just stay committed to that practice. Of course, our fees are much, much higher, but our cost of living is much, 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 much.
correct.
Yeah, it's that everything's
Yeah,
relative. And I find that sometimes when dentists come over to Australia from South Africa, they have a look at what dentists earn and they think everything's going to be sweet until they have to start paying rent and buying petrol and I don't know, eating. And then all of a sudden it's the glow
or
comes off.
paying
So
for garden
everything's
services.
relative. Paying for what?
For garden services. I know most expats that move out there in South Africa, we have garden services. In Australia, it's so expensive, they have to cut the grass themselves. They haven't done it for
Absolutely.
entire lives.
Absolutely.
I
I
think,
talk about this with some of my South African friends. My life's completely different. Garden services, having a cleaner isn't because it's expensive, man. You do it yourself. Child support with childcare,
yeah.
whole
And I think
different ball game.
the, this is such a valid point that we're making right now because it goes back to clinical care as well. South African dentists would often say, we have to do this type of treatment because our patients couldn't afford it. Or it had to be a compromised care because patients couldn't afford it. And I think after having the privilege of traveling for work and dentistry and being exposed to clinicians like yourself in Europe, man, I was in Switzerland last year and I was at Professor Boozer's academy. And they were chatting about cases and they said, yeah, the patients couldn't afford a full mouth rehab. And South African dentists often think that our patients can't afford because we're living in this rand economy, not realizing the numbers are relative. Uh, Now we're sitting in Switzerland in the home of Straumann, and you'd think that a full mouth rehab would be affordable for guys out there, for patients out there. And it's not. And I think South Africans, we sometimes end up in the space where we start feeling a bit more victim-like and then looking at Australia and thinking, wow, a root canal out there is $12,000 or whatever the figure may be. Look at the US market and think those guys are making a lot of money. We're actually pretty much in the same space. And I think as a dentist, your financial outcomes should not be the driving force in your career changes or in your career moves because it's largely relative. I think if I was middle class South African Cape Town, you'd be middle class Australian out in Brisbane. It doesn't make you super wealthy above the rest. It's very
No,
much the
that's
same.
right. It is what it is. And you've actually touched on some points which are quite close to my heart. So one of them is I find it frustrating. Obviously, people have to pay for treatment. I understand that. I do understand that we don't live in a world where everything can be free. But I agree with you. I find it frustrating because sometimes I do feel it's used as an excuse for compromised care. And one thing I've never understood, and obviously what I'm going to say will be quite outrageous to some people, um, I don't charge for a lot of the treatment I do. I do charge for treatment. I mean, I'm not a charity, but it's not uncommon for me to discount fees, or if I've got a patient who's genuinely in need, I don't charge them. I mean, don't tell my principal. No, my principal does know. But but it's just I don't feel that it's an excuse to not treat, or I don't know. Sometimes if you genuinely want to help that patient, you can actually help that patient any day of the week, anytime you want. You have a choice. I get that's just my little I often hear people say, well, the patient couldn't afford the treatment, so I didn't. Well, you could
It's a
have.
tough one, because I see both sides of it. I didn't mention, but my mom's brother is a dentist. Um,
Oh, yeah.
played no role played no role in me becoming a dentist. So that's why I didn't mention it, because it's always you became a dentist because of your uncle. But no, my mom's brother's a dentist, and he runs well, he's heading into retirement soon, but he runs a GP practice in Durban. And he had this philosophy of dentistry the way you do it. Someone walks in, they couldn't afford it. He's like, I'm going to extract this tooth, get the pain out, move along. We don't have to make money off every patient. And if I look back in his life, I don't think he's short of anything in life. Uh, lives in a pretty decent house. They've managed to save, they've managed to invest, they've managed to do the responsible things. They've kept their cost of living to where the profession is. So they don't drive brand new cars every 3 years. So without chasing the banks, which happens very frequently in our profession, banks love throwing money at us, but living a very stable lifestyle within your means, they get to travel and do the things that middle class do. Um, I think he's pretty happy, because you get the other side of the spectrum where guys would say, you know what, you charge for everything, and everything has to be billed. Everything's a billable. Chair time is golden. Every hour has to have some sort of ROI on it. It's a fine space because, again, as a specialist, most of my work is elective tertiary level care, which does incur significant costs in that space. So I'm finding that balance between the two is important. At the same time, though, we also need to think about the patient's perception of the profession. Patients historically don't like paying for a dentist, and if a cleaning was $50 or $500, either way they're going to say it's too expensive. And I do think that when patients pay some figure, it attaches a value which makes them take care of what they're doing or what they have. Um, yeah, but I definitely think that we got to find the space between the two, but also without self-sacrificing entirely.
I absolutely agree with you. And I don't think we're going to solve this problem today, but it's very interesting to know that it's something we're sitting in very different countries, yet it's a problem that we're both aware of, and interesting that we hold a similar view, I think.
Mm.
So
I I
we've
think
talked about,
because
oh, sorry.
sorry, because that's also pretty much rooted in our business model of medical aids. Do you guys have something similar out there?
I don't know what's medical aid, and then tell me and I'll be able to tell you.
Okay, so medical aid would be is that you pay let's call it a financial institution, a certain amount of money every month, and they give you annual benefits for,
Yeah,
amongst
we
other
have
things,
that.
dental
Yeah.
care.
Yeah. Yeah. So we call
Uh,
it health
but they are
insurance. So yeah.
health insurance, okay. But each medical aid would govern rates. So we've got a variety of medical aids, but there's no set rate for consultation, or let's call it a one surface filling. A certain medical aid would charge you, sorry, a certain medical aid would be willing to pay $500 for one surface, another would pay 600, another 800.
Yeah. Yeah.
And I
Yeah.
think
Yeah.
this is where it comes in. You get a patient on a certain, so you as a practitioner know that your cost of that procedure would safely should be 500 Rand for that filling. If a patient comes in and their medical aid is only willing to pay 450 Rand for that filling, do you now make that patient pay a 50 Rand co-payment, or
Yeah.
do you write off the $50? And I think that's where the space that we're talking in does come through.
Yeah.
Um,
In Australia, generally, the health funds wouldn't pay as high as the majority of the fee. There's a copay, but the Australian health fund system is actually, health insurance system is actually quite complex in that there's so many different funds and there's so many different fund rules and things you can and can't do. But generally, from a patient's perspective, if they're paying money into their insurance every month and they feel it's a lot of money, right? It's not cheap. And so they're paying money into this insurance, they feel like sometimes that they're not getting anything back from it. But respectfully, that's actually between them and their insurer, because what they're paying to their
100%.
insurer and what their agreement with their insurer under their policy is separate to what my fee for a one surface filling is. My fee for a one surface filling is set on how much it costs me. So I'm an associate, I'm a locum technically. So what that means is I work at the same place, but I'm there infrequently. I fit because of my work with dental protection. I fit in around the other practitioners. So I'm a true, yeah. Anyway, I'm on a percentage. So it's what the filling costs and then what my percentage is, because I have to pay a big chunk of my fee as an overhead, as a service fee to the practice for having me. But the patients don't see any of that, right? They just see, I pay my health insurance this much and you're charging me too much. It's an interesting,
I think
yeah,
I think at the same time, even if you are a sole practitioner, the same applies. A sole practitioner who doesn't have to pay service fees still has other costs, rentals and staff salaries and so on and so forth. I think what patients need to start realizing though is that the health insurance or the dental insurance or the medical aid is not an authority to dictate the price or the cost of a certain dental or medical procedure. And somehow over the years, patients have been brainwashed into some ideology that that is the, the recommended retail price of a filling. Um, I think historically it does come back. If I check to older dentists in this country, they would say, or they would talk about the golden days of dentistry, where the medical aids or the dental insurance ran like an open tap.
yeah,
Any
yeah.
procedure, whether it's a crown or root canal, it was approved. And I think back then patients started getting to the ideology that their medical aid card was their gateway to oral health stardom. Um, but I do think that the younger generation is now learning this. So we in that in between phase of where the older patients are need to be relearned or retaught how health insurance now works in these different countries or in these economies.
Yeah, because it's worked differently. That's really interesting. So I had some questions for you about like day-to-day life of dentists, and I think we've actually covered off on that quite nicely. So just so I can be sure that I've understood. If you're in a community dentistry setting, often we're talking about pain relief, and that's predominantly taking the form of extractions. You do some general dentistry, but a lot of those patients present with pain. Whereas where you're working now, I mean, obviously you're in a specialist clinic, so it's a different environment altogether again. You are doing a full range of dentistry, albeit you may not be doing every procedure because you have colleagues so you probably don't do much perio or endo because you have those people in the clinic where that's what they do. So you're working together collaboratively. Is that correct?
Correct, 100%.
Excellent.
Let's say community dentistry. Classically, you'd get to work at 8 a.m. in the morning, but you'd already have a line of close to 50 patients waiting to be seen. Those patients would have left their homes at close to 3 a.m. in the morning, 3, 4 a.m. in the morning to use various modes of public transport to get to the clinic by 6 a.m.
Because the clinic's a long way away?
The clinic's both a long way away at times, but more than that, because of the volume of patients that present to the clinic, they would work on a first come, first served basis. So the clinic can only hold or manage a certain number of patients between 8 a.m. and 4 p.m. Or the clinics could be limited with resources and can only see a certain number of patients per day to run the clinic sustainably for a longer period of time. So by the time you get to clinic in the morning, you'd already classically have a line of patients waiting.
Must
Um,
be quite stressful, is it?
it would be extremely stressful, I would imagine, for especially a new graduate. Can
For a
be
baby.
overwhelming that you get your clinic in the morning and this is what you're presented with. Also, it's obviously a big thing. HIV/AIDS is highly prevalent in Africa, and South Africa is no exception to that. So you also now pick up a lot of oral medicine, oral pathology. So you may
Yeah.
have incidental findings of these oral lesions, and that can be as simple as an ulcer, but commonly squamous cell carcinoma becomes a massive finding. the patients may present with what may be seemingly an extraction, but you're diagnosing various other oral health related issues. In the community as well, unfortunately, alcohol abuse is a big issue. Dental alveolar trauma will be a common presenting finding. So you've got a young dentist who comes in. I was chatting to one of the younger graduates now, and on his first day at work, 2nd of January, mandibular fracture bilateral. He's qualified a
What does
month ago.
he do about that then? So you're that baby dentist, 2nd of January, old mate comes in, bilateral mandibular fracture. What are his options now as this dentist at the community clinic? What are his options?
So so his options basically are limited to pain relief, antibiotics, basic analgesics, anti-inflammatories, antibiotics. Uh, if the patient is stable, then you now refer this patient to the local MaxVac. The local MaxVac would classically be a drainage for 15, 20 clinics. So you can imagine how long the waiting list would be for that type of care. I think
Gosh.
mandi mandibular fractures waiting list in the community, in the public sector is probably close to 6 months, between 3 and 6 months. So often these patients would have already healed or recovered before their fracture actually gets sorted out, unfortunately. Um, so baby dentists, unfortunately, get thrown into the deep end very quickly. Fortunately, they do work with supervisors, like you've met probably some of their supervisors who
Have,
work in the
yeah.
public sector, and they get to now mentor them and guide them and manage them through this process as they get comfortable with managing these type of patients. They would also do a bit of community outreach. You go to public schools, you at times doing extractions on normal office chairs or dental chairs that may not always work. It's just what the public sector is like in South Africa. In the private sector, you got a variety. You'd have the general practice out in the suburb that would see the families, see the kids, would have patients booked for the day, would obviously have the walk-ins or the emergency that will call in, but it'll be a lot more of a structured environment, but largely a medical aid governed space. But the challenge and where your conscious kicks in is treating patients according to their needs or treating patients according to medical aid benefits.
Yes, of course.
And simply put, a medical aid may not cover a post and core crown, but you know that it's in the best interest of the patients to have a post and core crown done, or do we extract and give the patient a denture?
Yeah.
You know that the best denture to have for the patient in that case may be a removable partial chrome cobalt denture, but the medical aid may only cover an acrylic. Knowing well the patient may not wear an acrylic partial denture for a single tooth, do you still manufacture it and deliver it because it's income and medical aid will cover it, but there's a high likelihood the patient may not wear it. And I think that's where those gray areas do come in, and practitioners have to now manage those internal challenges within themselves, um, and sometimes justifying things that they may or may not do for patients. In my case, it's a bit different. Specialist level case, elective, so we don't see emergencies unless it's a filling that's popped off or a crown that's debonded.
Yeah.
But a lot more structured, a lot more appointment based. And because we have a general dentist in the practice, he would see any overflows that may come through or patients that I'm not able to
Yeah.
see in that day. Um, within his space. Um, and the same also applies to dental laboratories. I'm not sure if you have any dental technicians that may be tuning
We
into
do,
this,
yeah. In
but
Australia, they make most of the dentures. So when I was in the UK, I was trained to make dentures. And in fact, we couldn't sit back in back in my day, Ridwan. We couldn't sit finals until we'd completed a certain number of both complete and partial dentures. I came to Australia when I was
sorry,
27.
is that is that the clinical and the laboratory work or the clinical only?
We had to make one terrible set, but then the rest were done because frankly, the dentures that we were constructing you wouldn't really want to be putting in patients' mouths. But we did have to learn to do it. Fast forward to Australia, very few dentists actually make dentures. There are dental technicians, or they're called prosthetists,
Ah,
who
yes.
are able to make and construct dentures. So the majority of the denture work in Australia is not actually done by dentists, it's done by dental prosthetists. And it's really interesting because some of the practitioners, because they've never had to do it or they've not done it regularly, a lot of dentists they don't enjoy it, they don't have the skill set. I mean, I don't think anyone when they're young, full dentures are a bit more of an art than a science, aren't they? But that's sort of that completely de-skilling altogether. But luckily, there's a group of people who are amazing at making dentures, and they tend to do all that work in Australia. Does that make
Yeah,
sense? Yeah.
100%. We call it, or it's the term that we know it as denturism or denturist. I think that's the term that I've heard they call
Yeah.
denturist. Yeah.
Yeah.
So in South Africa, that doesn't exist. The dental technicians are trying to have that part of their scope where they themselves fabricate removable prosthesis. Um, there's a whole lot of issues around that, whether it's misdiagnosis or non-diagnosis of oral lesions, and there's a whole lot of red tape.
That's
I
the
don't think it's going
issue
to
there.
happen. Yeah.
That's the
Uh,
issue
but
there, I think.
Part of our undergrad training, similar to yourself, we have to fabricate dentures. We make the first two dentures ourselves, which we have to deliver to patients, and then the laboratory does chip in afterwards. But where this now cascades when you look at the health insurance or dental insurance or medical aids would cover clinical fees for dental technicians as well as for the dentists themselves. But the medical aids pay us as the practitioner and we pay the laboratories. Obviously, they would invoice us and then we pay them. So there's also prescribed rates on what the dental technicians can charge for certain lab procedures. And it puts the same spin that we have onto them, that they now need to seem more lucrative to dentists. So if a medical aid rate for a dentist was, for a denture was say $500, $500, and they would try and have that rate drop to $400 so the dentist can still charge the $500 to the medical aid, but they can profit or pocket that extra $100. And that's things that now become very gray in between, because how does the laboratory start cutting costs? So your quality
Yeah.
of denture teeth will drop, whereas a
Yes,
denture
of
tooth
course.
may last 5 years, may now only last a year. A denture acrylic, one would be a lot more porous than the other, uh, the strength, etc., etc. So our profession, like any healthcare profession, is largely governed by the greater conscious of the practitioner and how they want to practice healthcare and how they perceive treatment to be for patients. And because I was asked this question once, am I a businessman or a practitioner? And I said, I'm a healthcare practitioner. My business nature is secondary, because if I was a businessman, you're going to find the cheapest, the quickest, the easiest. Healthcare, unfortunately, would become secondary to that. And I think that's probably a question that I'm glad that actually Yash asked me that question last week. But I think it's a question that most practitioners need to ask themselves more frequently. Am I a businessman or a
Yeah.
healthcare practitioner?
I'm not surprised Yash asked you that, because it's something that we talk about all the time. So for colleagues who are listening who are not sure who Yash is a dental legal consultant who's based in South Africa. So friend of both myself and Ridhwaan. So someone who does the same as me in Brisbane, except he's doing it in South Africa. And one thing that we talk about a lot at Dental Protection and at MPS is this tension that we have between the professionalism and who you are as a professional and the commerciality of dentistry. And it has to intersect somewhere. And it's going to intersect at a slightly different point for different people, also depending on different circumstances. It's not a simple equation, but it's an interesting question to sit and reflect on from time to time as a clinician. It's just an interesting question to reflect on, and just where you sit, or where you sat on that occasion. And you might surprise yourself sometimes with the answer, I think. One thing I wanted to ask you, when I was over in South Africa last year at your wonderful, and it is a wonderful conference, the SADA conference. I
Thank you.
absolutely love it. Oh, it's wonderful. You do such a good job. You're on the scientific committee, aren't you?
I'm on a scientific committee. Yes, I am.
Great work choosing such amazing speakers. Anyway, I was talking to this beautiful orthodontist, and he was telling me about going through phases where there's no water and there's no power. Is that something that's still happening? Because I wasn't sure if he was talking about that as being a now issue, or about that as being an issue that was happening. Is that something you're still facing? I don't think it really impacted Cape Town, was my understanding, but I think it did impact other parts of South Africa.
Um, it does impact other parts of South Africa. It's not, I won't call it as a general thing. Cape Town, generally, the municipal services or public service delivery is a lot more efficient. Electricity cuts was a major issue. I think it was about
And
2 or 3 years
brownouts,
back.
hey, you had brownouts
Blackouts.
too, didn't you? But you had just full blackouts. You didn't have brownouts where they just reduced it so your lights would dim. It was just completely cut, was it?
Oh, is brownouts a thing? I don't know.
Brownouts is a thing. Yeah, yeah, yeah. Where there's not quite enough power. So all the lights will just
Just
dim
dim
and
out.
no one
No,
gets
no, no. We have
Wi-Fi. And then it
blackouts.
comes
It
back
goes
on
off.
again. Okay.
No, no. We just go dead. Just complete radio silent. Um, and that happened quite frequently about 2 years ago. And I think for last year we had none of it at all.
Okay, that's
Um,
good.
Water issues, we don't in Cape Town, we've never had water issues here. We have more than enough rain. I think what does tend to happen is firstly with the blackouts, most practices became self-sustaining. We have a generator, these practices have inverters, so you eventually realize you make a plan and you get things to work. The practitioner that you were talking about could have been based in Johannesburg. Johannesburg is known, unfortunately, for having water cuts, electricity cuts, and those are largely because of municipal services that have failed, whether it's the pipes or the drainage or the cables that get stolen, unfortunately. So these things do happen more frequently than one would like. And it can go on for extended amounts of time. You're looking at a week, 2 weeks at a time. And this doesn't just affect practice, it affects your family life. It doesn't affect
Of course.
commercial uh, e- entities. So it is a major challenge, and that's probably also what's led to the so-called internal semigration to the Western Cape. A lot of practitioners and families, not just in dentistry, outside dentistry, have moved down to the Western Cape for the perceived nature of improved service delivery down here.
More predictability. So your water then, I'm curious. We have in Queensland, um, the water quality, we have heaps of rain in Queensland. So you mentioned it being like Durban. It's very humid. It's what time? It's 7 o'clock at night. I'm hot. I've got my aircon on. It's summer. It's still 30 degrees. Like it is humid. You can ring, you could
Yeah,
ring me
that, that,
out
that is
some
that is
mornings
Durban.
after
That
I,
sounds about Durban.
just like Durban, right? So we have heaps of rain in Queensland, but so we don't have water shortages up here generally. We do go into drought from time to time, of course, but our water's not very good quality. So for the dental chairs, we have to deionize our water, whatever that means, and have some sort of unit to make sure that the water that's running through the chairs is actually not going to trash your equipment. So it's not that the water's not good quality, as in it's polluted. It's that I think it's that it's really hard and it basically is just going to gum up all your equipment and nothing's going to work. What's your water quality like? Do you have same
Very much the
issues,
same.
different issues? Yeah.
Our water is safe for drinking. So
Yeah.
it's safe for drinking, but our dental chairs have that same unit, that deionizing thing. It goes into some little machine, then the water is perfect, and then we use that separate water afterwards. So it's exactly the same situation. The option of working with the water is there, but then your risk of your handpieces and your cables and lines getting damaged is increased. So we've just played it safe. Let's not break good brand new equipment and had it
Break the
off the
equipment.
municipals.
No,
Yeah,
that's fair enough.
costs money.
But also, so in Australia, huge country, most people live around the outside. Obviously, we do have people who live in the middle. Most people live in coastal areas. Obviously, we're talking in generalities. There are lots of people in Australia who do not have access to what we call town water. So, water that is piped and you turn on your tap. So, lots of people have what we call tank water. So, they have rainwater or they have their dam. So, they have their water supply, which is like a lake on their property that they drink from. My understanding in South Africa is not everyone has access to town water, too. That's correct, isn't it?
That is correct. Living in cities and suburbs, most of us have access to water in tap. But if it wouldn't be uncommon that as you leave and you enter the countryside, a large population would be carrying waters from the river or a central communal tap on wheelbarrows or in drums, and you move along with that. Unfortunately, that water quality at times can be more compromised because at times the same river or dam water is being used for other lifestyle things, washing, cleaning, etc., etc., and then water for consumption can be dangerous for some of the population. But again, we're talking, and I think this is what makes South Africa South Africa. We've got these two extremes. You've got the opulence of Cape Town, and then you've got what the large bulk of our population can be, who lives out in rural areas and needs to travel. a kilometer to get fresh water at times, unfortunately.
It's extraordinary, isn't
Yeah.
it? Absolutely extraordinary. And of course, it answers the question that some of our colleagues were thinking. Oh, and you and I were talking right back at the start about your big queue of patients in pain and sepsis. And why don't you just fluoridate the water? Um, because the people who need it
Let's not
aren't
let's
drinking
not
that
go there.
water.
Let's not go there. Yeah.
But
Fluoridation of
you
water has
can't,
been this age-old debate. You can't. Yeah,
it's not reaching you the right population, right? It's not, the
exactly.
people who need it
Exactly it.
wouldn't be getting access to it.
100%. And the rest of us want to buy that off a little box at a pharmacy. Um, yeah. Look, you do get individuals out there, especially in the city, who still don't trust city water either and would have various filtration systems. Um, Cost of water is something that becomes a factor as well. So it's not uncommon. I think Cape Town had a massive drought 2017 where where dam levels were pretty low. Um, and that's when lot of people ended up, especially those who live on large premises, would have boreholes dug up and use their own internal filtration systems and things like that. So there's quite a few homes that now heading towards that off the grid type of lifestyle. Solar power, borehole water, and you're not
Doomsday
using them
prepping, hey?
pretty much. That's
We all have solar panels in Australia. Well, not all of us, but where I live in Queensland, we get so much sun. You would be an absolute fool not to have solar panels. And we also have generators, but it's not for loss of power, as in you're talking about. But of course, when we have cyclones and things like that, we can lose power for weeks.
okay. Okay.
So it's a whole. We had our first cyclone in Brisbane in 15 years last year, and we were without power for, but I think we were lucky maybe 4 or 5 days, but it creates all sorts of issues like you're saying, like the food in your fridge spoiling. But it also means that we get to use my favorite thing, which is like, you know, the wind up radios. Oh, I love those. They're so
Ah, yes.
1920s. Love that. Love that for
I
us.
haven't
I'm
seen
such a
one of
toddler.
those in ages.
Well, mate, I one in my kitchen cupboard. So a sensible Australian has a storm pack or a cyclone pack, which contains in it candles, water, snacks, um, you wind up radio, torches, because if we
Wow.
lose power, we lose power. Yeah. And in the, I love this in our Wellington office. It's they have a pack in our Wellington office, which is an earthquake pack, which is something really similar. So at the Wellington Dental Protection MPS office, they have these bags that have all the stuff that you need if there's an earthquake, because you're supposed to get under the
Wow.
table if there's an earthquake, apparently. And they've got all sorts of things in there, including snacks and water. And yeah, it's we live in a mad
Incredible.
world, Ridwan, and that's
Yeah.
one of the reasons I wanted to do this particular podcast series is because I'm naturally quite curious, which you probably have noticed over the time we've known each other. But I think it's really interesting the different challenges that we do experience as practitioners. There's commonalities, and we've talked about one at length today, that tension, as we were saying, between the commerciality and professionalism space. But then those vast differences of what we are and are not able to do within our communities, what public health measures are available to us, and the challenges, the barriers that our patients seek to care are very, very different. So we talked about the sepsis toothache. As a general dentist, I'm presuming that with your practice isn't like that. You're seeing more general dentistry. So we have a huge drive towards cosmetic dentistry in Australia at the moment, as in people wanting multiple veneers. It's very, very popular. It's very much on the increase. I blame Instagram. Are we seeing something similar in South Africa?
We definitely are. And I think it's definitely a global phenomenon. Patients will be coming now wanting veneers, asking about bonding, things that or terms that we would generally tout between ourselves. Clinically, patients are now asking us, "Can you do the ABCs, align, bleach, and bond, or ABBs?" And you're like, "Wow, okay, where did you learn that?" So patients are coming to us a lot more informed.
GPT.
Yeah, there we go. And the crazy thing is, and this is where, as a specialist community in South Africa, we always have this conversation because one, I think dentists now start calling themselves cosmetic dentists and aesthetic dentists. Um, and I chatted to Yash about this last week as well because I have a problem with that. I feel like by giving our profession these weird titles, we're almost devaluing the profession itself. You would never find a GP medical doctor saying that I am a skin doctor. I'm a I'm a dermatology GP, or they've got aestheticians, but yeah. So I think we using these terms for marketing, and then I'm not sure if Australia has the same thing, but there's no regulated scope of practice. So
No,
what
we've
allows or what would qualify a practitioner to carry out a certain procedure? And as a specialist, we're pretty much well defined. As a specialist prosthodontist, I can't extract, or I shouldn't be extracting teeth. I can't bill for placement or surgical placement of dental implants. The medical aid codes wouldn't allow it. You'll kick it out. But a general dentist will be able to bill for 28 crowns. And how does that work? And again, it's one of those questions that we're never going to have answers to. Uh, but where do we draw the line of training and education, the ego of a dental practitioner as well? I can do 1 crown, so I can do 4. If I could do 4, surely I can do 10. And if I need to buy the new car or the new shoes, I need to do 20. Um, but the clinical skills and knowledge that goes behind that is very different. And the
Mhm.
appreciation for various aspects within the masticatory system is very different. So I think patients themselves now need to get into the next space that, yes, they may want or need cosmetic care. Let's say they need cosmetic care, but reaching out to practitioners who are adequately skilled, and how do we regulate this upskilling process for them? Because Yash and I also had a conversation about this as well, and would love to hear your thoughts on it, that dental education in South Africa is largely the only regulated space is the universities. Let's not It has their problems, they have their issues, and we're not going to go into that. But if you look at the Health Professions Council of South Africa, they accredit the universities for an undergraduate, a diploma, a master's, and a specialist program. Um, but any other information that dentists acquire from private organizations or institutions is largely open. They apply for CPD points and you get CPD points, but there's very little control on that assimilation and distribution of knowledge. And how do we manage that? Because it's also a very lucrative business coming from that space as well. Yeah, so I think I'd love to hear how you guys do it on your side. Um,
It's the same.
the same.
So for a country that loves rules, and Australia loves rules, you may
That's
have
strange.
noticed. All right,
Yeah,
well, considering we're we have like a 200 years ago or whatever, it was basically a whole lot of convicts came over, you would think that Australia would be the other way and not love rules, but Australians love a rule. But our scope of practice, you have something called your division. So that's whether you're a dentist, a specialist, an oral health therapist, whatever you are. And then within your scope, it's what you're educated, trained, and competent to do. So it can be broadly, vastly open to interpretation. And we often see what we call scope creep. Normally, people creeping between divisions. So people who are doing stuff that they're not actually educated, competent, and trained to do because they didn't do it at dental school as a basic. Yeah,
as a
crown being a
basic, yeah.
classic example. Only dentists and appropriate specialists can prepare teeth and place the crowns and place them, right? So with the CPD, it's the same thing. APRA, our regulator, doesn't accredit CPD courses. We have fascinatingly a purely reflective service. So you as a clinician are supposed to undergo a period of reflection where you consider, what do I do? What's my day-to-day dental practice look like? Where are my gaps? What do I want to grow in? What am I interested in? And then you select appropriate CPD to meet your requirements. So as a specialist prosthodontist, the expectation would be that your CPD log would be related to all the stuff that was relevant to your specialty. You wouldn't be doing, I don't know, extraction courses in Bali because you get to go on holiday. That's not what your CPD log should look like.
Okay.
But you're only going to get caught if you are one of the lucky people audited, and ARPA do audit annually. So I actually did want to talk about CPD because obviously different across every country in the world. So in Australia, we have a 3-year CPD cycle, and you only have to do 60 hours across those 3 years of appropriate reflective CPD. So as a baby dentist, they expect to see a whole load of hands-on, okay?
Yeah.
And then you're supposed to do stuff that's relevant to you. In that, there ought to be
Okay.
some sort of CPR annually, um, that kind of stuff they would expect to see, infection control, updates, like so stuff that's kind of relevant and keeping you safe. Yours would be very different. And there's something about South African CPD I love. So first of all, hours to hours, is it similar or the same?
The same. Hours to hours, similar. I don't know if it's exactly the same. I end up accumulating these as
Me too.
like sweets, but yeah, very much the same. But we don't do it as a reflective. And also, we could be in Bali doing an extraction course as a prosthodontist, and I will get those points.
Oh, okay. Well, there we go. We'll look one
Yeah.
up for you. It's a beautiful place. One thing that I love about South Africa, though, is that you have compulsory ethical CPD, don't you?
Yes. And I
Love
love it
that.
as well because me myself, I'm so neglectful of the ethics points because no one enjoys those lectures up until you started coming to South Africa
Absolutely.
for
I was
them.
going to say, I can't
Uh,
believe you even said that to my face, Ridwan.
uh, but no, for real, I think you guys have done an incredible job at changing the platform and the narrative of how we perceive these
Thank
ethical
you.
lectures. Yeah, and hats off to you for doing what you do for us. Um, but it's allowed us to now engage in the subject matter, which we unfortunately at times don't appreciate the value of up until you're in a problem, like most insurances. Um, I think where it does become tricky is what qualifies you to be in a position to host that CPD.
Yeah.
Obviously, you yourself, I'm not questioning you as an individual, but um, and, and I'm touching on this because I've had the privilege of lecturing in Sudan, and that was one of my first lecturing gigs back when I was still a resident. And I landed in Khartoum. I was there 4 times on 4 separate occasions, and I landed in Khartoum, and I promise you, down one street, I saw 5 training institutes, 5 private training institutes, um, and all of them were hosted by, at random, any general dentist or any specialist who wanted to host a course, whether it was a prepping of veneers or one surface restorations or implant placement for that matter, you do it. Um, and I, as a South African, landed in Sudan to give lectures on various restorative principles. But what qualified me to be in that space to lecture to an audience other than the fact that the organizing host of that organization felt that I could add value? And I'm saying this because I was a beneficiary of it, but looking back and I'm thinking, no one actually checked to see, am I actually a real dentist? Am I registered in my country? Or let's say I am registered. Obviously, I'm registered, but I'm registered. But what allows me to teach you to cut
Yeah.
crowns?
No, I
And by
understand.
virtue of
That's
my experience, doesn't cut it, unfortunately, because we know the whole hierarchy or that triangle of evidence, and expert opinion is the lowest form of it. And if I am teaching you off experience, I probably learn 60% of subject matter. I remember or retain 30% of that. And if I'm sharing 30% of what I've actually retained after 10 years, how much are you learning as first-hand information? 10% of what 100% was. Yeah, I don't know.
that. No, I love how reflective you are. Actually, it's a really, really interesting. We could talk about this for hours. It's a really interesting concept. Yeah. No, I love that. So I think I'm getting a bit of a feel for some of the challenges which you're facing in South Africa. It sounds like the Medicaid is not dissimilar to our health fund issue in Australia, whereby the health funds in Australia are sometimes dictating the treatment that the patients have by what they will pay for, as opposed to what the patients actually need. It sounds like you have some discrepancies between the people, whether practitioners asking themselves whether am I the right person to be providing this treatment sounds like an issue which is occurring in South Africa. Should it be me or should it be someone else? But I'm really overarchingly getting that probably one of the biggest issues that you're facing is there's a huge gap between the types of treatments that certain groups of patients are getting. Is that right? Some
Yeah, that's right.
patients
And
would
I think
never
that
be able
would,
to come to your clinic, right?
Sorry,
Some patients would never be able to come to your clinic. They wouldn't, it just would never be on their list of wants or needs or.
because of affordability. Yeah. I think so. I don't like using the word challenges because challenges at times has a very negative connotation to it. I prefer saying it's a these are variables that can limit the way we execute our profession. And I think it's important to look at it as variables and not challenges because as soon as we use the word challenge or it has that negative feel, we start putting ourselves in a different box. And we need to realize, and I've realized that, okay, when I was a general dentist, in those 2 years while studying, I didn't want to open my own practice, so I worked between three practices in a day. I'd work at one practice in the morning till 1 p.m., from 2 p.m. to 5 at another place, and the third practice was from 6 p.m. to 8 p.m. And the demographics were vast. The one was in Cape Town CBD, not too far from the CTICC, which you've been to. The other was out in the suburbs, and the other was in what we call location. Classically, let's call it a lower income area. And the one night I remember going home and doing my thing, washing my hands, washing my face, and I thought these hands extracted the same premolar 3 times today, but they charged different rates throughout the day, and
Interesting.
that varied significantly. And I think what's important is that a practitioner would need to realize that if my practice is set in a lower income area, that is the level of patience and care that I need to offer. And we can't think that if I'm practicing dentistry in this space on this so-called business model as you have it, I can't do full mouth rehabilitations here. My practice setup isn't geared for that. And not to say that that becomes your identity forever, but if you would like to move into that space of carrying out full mouth rehabs from that practice, you need to invest in education, which is not going to bring an immediate ROI for you today. So you're going to be spending a lot of money for the first 2 years, and then you need
And
to find a
time.
location and time. Find a location that is amenable to attracting these patients, that has equipment that allows you to execute this, whether
And
it's
staff to support
CBCTs,
you.
intraorals, support staff. And often we see practitioners who say, we're starting up small and we'll grow. But at what point do you say, I've outgrown this practice and this place, and now I need to be carrying dentistry or want to carry dentistry in a different sector of the market, but I need to find a practice that's representative of that.
Yeah.
Um, so I think it's, again, self-reflection.
Oh, for sure. Definitely. So these patients you were telling me about who are walking for hours to see a dentist, what do you think South Africa could do, big question, to improve access for these people? Do you think it's just a case of throw some more dentists out there or pop up a clinic? Or in Australia, you see, because don't forget, we have the flying doctors service where we fly out to remote communities. And of course, we also have the vans. We have mobile dentistry that will go out to rural communities and rotate rounds to try and get the dentistry closer to them. It is an imperfect solution, but it is a solution. What do you
Solution.
think? Do you think it's just a resource demand inequality? Do you need more dentists? Do you need more money? Do you need more everything?
In the ideal world, we want more of everything.
Mm,
But I think, okay, so firstly, we're talking about patients in the rural areas. We're talking about
yes.
patients who don't have access. Remember, like we're talking about patients who live off government grants, large unemployed individuals. Um, I think the first thing is that the government itself, as much as there's the corruption, like every
Yeah.
government has its budget issues. We shouldn't think that it's unique to Africa. I was in
You're
London a
very
couple of years ago.
candid about it, though. I noticed that when I was over. Some countries uh, act like their everything in their world is perfect. One thing I found quite refreshing when I was over there is people are quite candid about areas where there have been issues in the past. Like there's no, I don't know, that nobody tries to pretend things are something that they're not, and it's quite
Yeah,
refreshing, I think.
I was in I was in London in 2023, and I always put the radio on wherever I travel because you get to hear what the real people think of in the
Sure.
country. There they were still talking about a post-COVID inquiry about PPE fraud. And I thought, that's no different to what we had in our country. And it's a global thing. So I think the first thing is that our government is, as much as we may say that there's corruption, they're also doing their level best. And they're fighting resource issues of, do we give dental more money, or do we give the fight of HIV, AIDS, TB, malaria in some areas of the country or the continent, health issues, diabetes, what are these issues? I think if we take healthcare down to its skin and bones, there's interventions out there to have sanitary pads sent out to young girls in high schools. That is the level of care that patients need. So we shouldn't feel that the government has forgotten about dentistry. Maybe some of them have, but they haven't forgotten about it. It's just that the resource burden has become so broad. Um, and these areas are extremely rural, extremely remote. So I think in the ideal world, we'll want the government to give us more, but we got to think about the bigger picture. What is satisfying and rewarding to see is that there are interventions that get out there. When I was a university student, Transnet, the company that manages our rails and ports, has something called the Philippepa train. Basically, it's a community outreach train that takes on dental students. I think it was pharmacists, optoms, dietitians, OTs, and 12 of us per dental class go out for 2 weeks. And the train
That's
goes to
cool.
areas of the country that doesn't get access to care at all. It was absolutely remarkable. I remember going to a park in the Free State, and this little kid comes up to me and he touches my skin, and then he touches my hair, and he was confused because how does a brown person have straight hair? And I was like, wow, like it's so beautiful to know that interventions like this happen, that we're getting access to areas where this little kid has only been exposed to either Caucasian or white individuals or classically African individuals. And he didn't know that there's a space in between for other people. So it's really, really rewarding that we have interventions. I know the university, for example, as much as we're treating patients at the varsity, they run weekly outreach clinics as well. At night, students can volunteer, and this runs successfully at the local primary schools where the communities come around as well. So I think there is this collaborative effort between the public as well as the private sector where there is an element of giving back. But there'll never be a solution. There's never going to be this fix that we've sorted oral health or medical health on the continent out. You guys have the challenge, so it'll be delusional of me to think that we're going to fix it here. I think it's just important that each of us, and this is you and I included, are intentional about giving back a certain percentage of our year and our time to these people, to patients, to the community. It doesn't cost us much to say, let's give a weekend away. And there are organizations that are always looking for this. I
Oh,
know
for
even there's
sure.
local community-based organizations within Cape Town CBD that run local clinics. I know when guys are retiring, as opposed to selling off their practices, some of them would donate their equipment to these private community-based organizations. So I think we also think about our legacy. It doesn't have to mean what we've done in a visual sense for our legacy, but give off your old mirrors and probes and extraction forceps. Um, we can think about things in a bit of a broader sense, but don't wait for someone to fix it. Don't wait for the government to say, you fix it. It's your problem. I pay taxes. I think every individual needs to take accountability for their community and what they want to leave the world behind, or the dental world behind.
That's such a beautiful message. And what do you love about being a dentist in South Africa? Why? What do you love about it? Is it because it's your home? Is it? I love Cape Town, so I can understand that. But what do you love about it?
Let's put it out there. I love being a dentist. I love being a dentist, prosthodontist. I love what I do. I think if I was anywhere in the world, I would love it. What makes Cape Town particularly special for me is that I've got, and maybe I'm just being biased, but I've got the feel of people, culture, community, the multi-racial, multifaceted individuals that we have. And you've seen it in this country here. Um, I love the environment that we work in, but particularly I love the fact that we also have access to first world care. Obviously, it's a privileged few that can get it, but we have access to first world care. We have access to executing first world treatment. We, I personally would say South Africa has that perfect balance between the humanity of the world, but also having access and execution and treatment and education of the first world. I wouldn't change South Africa for any place. I think I've had this conversation myself. Would I immigrate anywhere else in the world? And I wouldn't. Um, it would be very hard for me to leave this place because it's got everything that I think I would want. Cape Town specifically, within 15 minutes, you've got the mountain, the ocean, and a shopping mall, and a
Yeah.
20-minute way away, you've got the countryside. Um,
And amazing
how did you
wine.
ever? How do you find that anywhere else in the world? I don't think you could.
No, and you're a
Um,
beautiful community as well. That's one thing that struck me the couple of times I've come over. You are such a beautiful dental community, and you're very supportive of each other. It's actually, you're quite a delight, I have to say. So,
I think
if
we,
some,
I think we, I think, sorry, I think something else that we also just have to look at beyond dentistry. If you look at our history, we had democracy in 94. So as much as we've got a troubled history and it's been a real troubled past, I personally love the fact that we open about it, we own it, we're honest about it. It's not a comfortable conversation to have on whichever
it's
side
one
of
you
the
need to
spectrum
have,
that you're
Ridwan.
at.
It's one you
But
need
I'm
to
but
have.
I'm glad and I'm grateful that we have these conversations and it's not something that's hush hush, this is South Africa and we've forgotten about the past. So I think that also our our diversity is what unifies us. And I think that's what makes it a special place to live in as well.
Yeah, diversity and your honesty, that's for sure. So if someone's listening to this now and they're thinking, I might give South Africa a crack, it sounds like it's for me. What advice
Please
would
come.
you give to an overseas? Kami says we've got plenty of space for you. What advice would you give to an overseas trained dentist who did want to practice in South Africa, do you think? Do you think it's an easy transfer or do you think it's a bit of a steep learning curve?
Um, I think it I think the first thing is getting your examinations to enter the country can be challenging. I'm not sure how it would work for someone that has already qualified. If I talk to dentists who've studied abroad and then want to enter the country, they sometimes have to wait between a year to 3 years before they get to sit a so-called transition examination to enter the country. And this would also apply to dentists within the continent. Specializing in South Africa is not possible, well, not as a rule. I'm not saying as a rule, it is possible, but if you're not South African citizen, it's very difficult to come and specialize here. You can come and do a master's here or clinical master's, but to join a purist specialist program um, doesn't always work unless there's a different conversation that's had with the university. To work here, I think it would be a different space to understand how life works. Clinically, we're treating patients. So, as I said, if you have left Brisbane or Perth and you come into Cape Town, be, I've been to dental practices in Perth. It feels like home. A dental chair, the CBCT, the Pan, Straumann, Neodent. Our brands are global, so your
Absolutely.
equipment and
Same
materials
brands.
are exactly the same. I think what is a change and understanding is if you come with families. Remember, your schooling systems would be different. Public schools and private schools. Your transport system in South Africa, everyone owns a car, so you have to
Yes,
have a
very
car
much
because
so.
the public transport system doesn't allow that.
It's
Um,
unreliable.
Unreliable. We also have, yes, safety and crime is a well-published problem of our country. So the areas that you live in, understand where you want to live, what's the locations of where you want to live to where you work, because that can also severely impact your cost of living as well. Cape Town's a beautiful place to live, but it's an expensive place to live. Um, and I think be aware of the lifestyle changes that can happen. Because once you're aware of the variables that come into play compared to where you come from, it's different. I think when I traveled to Europe, people would hop on a train and get to work and walk 2 kilometers, and on the train they're working with a laptop and things are good. Uh, we are crime vigilant in this country. You wouldn't just walk
Be a
around freely.
terrible
So I think,
idea.
yeah. So I think it's more the areas around dentistry that you'd be aware of. And once you find those spaces, then life can be equally as rewarding, if not more, where you're coming from. Yeah, I think Cape Town does lend itself to being the most diverse space where internationals fi- find it quite comfortable to be in. Johannesburg is a bit of a different space. You get pockets of it. Um,
Yeah, they're very different places, that's for sure. And then
When are you
last,
moving back?
I don't know what my husband would think about that. He's true blue Aussie. They can't leave Australia for too long or their
Oh, there
arms
we
and
go.
legs drop off. Yeah. So, if you could give one piece of advice to new graduates or aspiring dentists, Ridhwaan, they're listening now, they want to be a dentist or a prosthetist, just like you, and a prosthodontist, just like you when they grow up, what would be the piece of advice that you'd give?
Two different. An aspiring dentist, I would tell them spend time with practitioners, engage with practitioners on the elements of a working day, your finances. Know that your income is not stable salaried. It's very different to when to work, not no work, no pay. Understand that you're dealing with patients who come with certain negative nuances towards you and the profession. It's not personal, so you have to have a bit of a thick skin, strong personality. I hate the dentist. I don't hate you, I hate the dentist, but it's still quite a hurtful thing to hear if you're not prepared for it the first time. So engage with, as an aspiring dentist, engage with the profession. Dentists love talking, so engage with them on the profession as a whole. The flexibility that it offers you specifically. You're able to have two different jobs. It allows you to be a mom as well. I'm sure if you had one
Absolutely.
job, you could be with your kids. It's a very different space. For young dentists, I would say that you are in the most beautiful profession that I feel is available to us. It's a privileged profession, and don't use the word challenges, but use variables. Look at situations as opportunities rather than prohibitions of progression. I'm a practitioner living in Africa with the Rand-based economy. We're sitting at 16 Rand to the dollar, but I get to practice first world dentistry. I've been privileged to travel globally. Last year, I think I traveled 13 countries. Use your challenges and just spin it around. Variables and how do we work around it. And at the very least, if you really don't like the profession, don't do it to yourself. Don't do it to your emotional sense of well-being. Don't do it to your psyche. Don't do it to your family. It is a challenge, but remember, if you really have resigned yourself to saying that the challenge of being an architect would be better than being a challenge of being a dentist, then work your career out of clinical practice and either like yourself and Yash, who found a space that where they can still give fulfillment in healthcare, but away from being primarily clinicians, or leave the profession altogether. Life's too short to do something that you don't enjoy. And if there's no way out, speak to people around, get help to manage the challenges that can feel quite lonely
Absolutely.
at times. Uh,
Absolutely.
being a prosthodontist, being a dentist is not my identity. It's what I do, and I'm privileged that I love it. But my identity is a person, Ridhwaan. And you also want to self-preserve Ridhwaan as well, because he can only be of benefit to my family and my community if Ridhwaan is okay. So yeah, I think that's my two take homes for aspiring dentists and current dentists.
That's amazing, thank you, and I think Ridwan's a pretty awesome person to be, and I can
Thank you so
understand why
much.
you're that young person's favorite. I think that they are very lucky to have someone who is as reflective, but reflective whilst being supportive, not whilst being critical, supporting them through their clinical journey. So I'm really glad that you are working in that space. I think that's amazing. Thank you so much for your time, Ridwan.
Thank you.
I really
Thank you
value
for
it.
having me.
And of course,
Thank you
thank
so
you all
much.
for
An absolute
listening.
privilege.
Thank you, darling. It's lovely to catch up with you. I really hope we get to see each other soon. You have to let me know
We
if you
will
come to
soon.
Australia. But
We will.
so I'll sign off by saying thank you all for listening. And if you like Dental Protection podcasts and you'd like to hear more, please subscribe and leave a review. Thank you.
Bye. Thank you so much. Take care.
Thanks, Ad.